friends, welcome to the Purple Zone, where public policy, practice, and people meet. Because policy isn't abstract, it's personal. So let's talk about it. Hey friends, welcome to the show. It's Alexis, and today we're going to be talking about undergrad medical education and also $1 billion that's come into the state of Idaho for rural healthcare. And I'm really excited because I have an individual here today who's going to talk with us about this, and he's been at the center of so much of this on the legislative level. So today, Representative Dustin Manwaring, it's Dustin, right?
Yeah.
Oh my gosh. I have it written here, and then when you're like, oh shoot, is that the name? So anyways, Representative Manwaring, welcome to the show. And am I saying your last name right? Because I come from Oregon and we pronounce all of our letters from there. I grew up there.
Yeah. So, we say wearing.
Wearing.
Yeah.
Okay.
Yep.
Manwaring.
Yep.
You hit the N.
Yep.
Okay. Representative Manwaring, thank you for helping me know how to say your last name. I definitely should have said that before the show started, but I didn't. So here we are.
No, it's good.
Okay. So I always like to get started with a little bit of who are you and, how do you contribute to, what we're doing? So how, you're a lawmaker from Pocatello. How long have you been in the, at the Capitol, and how does what you do in your personal life help inform what you do at the Capitol?
I've been here. This is my 8th term. So I came in 2016, and then I had a gap year. So I lost the general election in 2018, and then I came back in 2020. So 8th year, this is my 8th year in session. And I think just going back to a little bit your question about, what I do in my other life inform why I'm here. And I'm an attorney, so I have a law practice in Pocatello. I do business law. But my motivation, kind of what makes me tick, is kind of the convergence of business law and politics. And so I really love policy. I really enjoy policy making. And that's why I have come back, even though every time you put your name on the ballot, for me at least, it gets harder because you know what you're getting into. You take on more responsibility. But what informs me is, my background in trying to help businesses succeed, and in particular Idaho businesses succeed, and trying to make sure the policy works for businesses and Idaho families, and that motivates me. But that's kind of the background that I bring to the State House.
Awesome. And I will say I saw something about, undergrad medical education stuff. My husband's a physician. I'm on another podcast called Idaho Education Unpacked. It's a partnership, like a collaboration with Idaho Ed News. And so we have an episode coming out all about undergrad medical education. So we break that down, and we're talking about what the terms mean and everything. And so in the process of, before getting ready for that, I had heard about this, these funds coming in from the federal government, and also just the, undergrad medical space. My husband follows it a lot.
Yep. And
so I went looking because, there's some lawmakers who have a thing, their category that, they kind of cover. And I really wasn't familiar with any lawmaker that was in this, medical education space. And so I saw your name. We'd never interacted before. And I really, I sent you an email, and I really appreciated, you just very kindly responded. You were clearly you care about this. Let's meet, lady,
Yeah.
So I really appreciated that. It was very kind of you.
Yeah. Well, and I think we do get identities as legislators, and I didn't come to the Capitol to be the medical education person. Some of these issues find you, and some of them you just, as you work on them, you sort of become the expert, at least on the policy making side, and realize, if you're going to do something, if nobody else is going to do it, you're going to do it. And this is one of those examples, right? I mean, if you would have asked me a year and a half ago, I know I way less involved than I am today, just based on some of the things that have happened last year. And as we go into what you've kind of alluded to already, some of this rural healthcare money coming in, I think it's just going to get more that way, where we're going to have a focus on what we're doing as a state and investing on rural healthcare. But a big part of that is education. And if we're not building that pipeline into our workforce, then we're not going to get the output on the other side. And so my focus is going to continue to be, as we talk through some of these issues, utilizing these funds on the front end to make sure we're getting and retaining Idaho students and getting them in the door into medical education seats, but then keeping them through the process through residencies, and then actually getting them employed, and then having their families be here, and so we can really change the course of where we're at as a state for medical education. And the ultimate goal is to make sure that we have better healthcare and access to healthcare for all Idahoans, and we have a long ways to go.
Mm-hmm. So when we're talking about undergrad medical education, I just want to make sure that we set some terms so everyone kind of knows exactly what we're talking about here. So when we're talking about undergrad medical education, it's an interesting term actually to me when they use the phrase undergrad medical education. I think this is probably the first time I've ever heard it used that way, because in the medical student journey, it's 4 years of undergraduate work that gets you a bachelor's degree. And then from that bachelor's degree, you go to medical school. And medical school is a 4-year program. And you get an MD when you're done with that. And that
or a DO.
Or a DO. Yes. Yeah. Thank you for that. Yeah, you can go to MD or a DO school. And so once they have, this is something that actually people don't know, that once an individual graduates from medical school, they're a doctor. They have that, they have that MD DO next to their name. And so from medical school, then they graduate and they go on to a residency program. And residency is generally, 3 to 5 years. And that's where you go into primary care or adult medicine. And, that's called internal medicine, emergency medicine, anesthesiology. What are some other ones? I can't think of them off the top of my head. You got any more that are just like residency ones where you just do the 3 to 5 years? And then from there, you're either done and you go out and you start practicing as a physician, or you go and get more training, and that's called a fellowship. And a fellowship is generally, 1 to 3 years. And a fellowship is even more specific. So if you're in pediatrics, if you do a pediatric residency, you can go into cardiology, you can go into, you do all the things that come off of that. So then or an oncologist. So you're a pediatric oncologist. And if you go into adult medicine and then you go into any of those, then you're an adult oncologist or adult cardiologist. And then, then there's surgery also. So surgery is general residency. And then you can specialize off of that, or an OB, right? So in total, I think I tallied it once. My husband and I did the entire journey was 14 years from start to finish. So when we're talking about all of those things, we're talking undergrad medical education. What are we actually talking about in Idaho? What does that term mean for this work group?
Yeah, and I think you did a good job kind of outlining that whole journey, medical education journey, but we're really talking about medical school. So when we say undergraduate medical education, or abbreviation, sometimes we just say UME, or GME is graduate medical education, but the undergrad is medical school. So those traditional that traditional first 4 years when you're going to get that certificate that says until you can be called a doctor, right? But as you've clearly outlined, after that you still have a journey usually to take to finish your residency or to specialize, to go into a fellowship, to really figure out where you're going to take your practice, right? And so, but we're talking about the front end, the first 4 years of that process to become a doctor.
Yeah. So now, you essentially, I'm kind of curious, how did this work group, this undergrad medical work group, come together, and what was the problem that you were trying to solve with this work group?
Well, there's a couple of things that have happened. I mean, I had been watching over the years graduate medical education get a lot of focus, which I think it deserves, and we shouldn't downplay that at all. I mean, that is a very serious place to continue to press forward and have focus and build out, because that's a big deal on retaining workforce and getting people to stay in Idaho where they do their residencies. And, there's plenty to talk about there. But I also saw a lack of emphasis and focus on the undergraduate medical education side. And the reason for that is because Idaho, the way we've done that traditionally in the past, and that's the WWAMI, or the agreement that we have with the University of Washington to do undergraduate medical education. We contract with them, and we have this the state consortium. That's what WWAMI stands for: Washington, Wyoming, Alaska, Montana, and Idaho. We all work together, and we do medical education, and they go out and do clinical rotations and can trade among those states. But that's how we've done it. Traditionally in Idaho, we haven't had another pathway until we've had ICOM as a private institution and in partnership with Idaho State out there in Meridian. We don't have our own medical school. And so that has been on my radar, just looking at how much we're spending as I've gotten on our Joint Finance and Appropriations Committee in the legislature, starting to really focus in on how much are we spending on medical education and seeing how much that we're spending, and are we doing it in the most efficient way? And what is the pathway going forward as we build out more GME to build those pipelines so that Idaho really is in control? And control is probably not a good word for Idaho, but control of our own destiny. Like, we're investing a lot of Idaho dollars. Let's do it in the best way and make sure that we're managing this in the best way. As we continue to build it, we have one thing, right? And that one thing has been WWAMI, and there's a lot of good there. But I just saw that we can do better. We can do more, and that was the opportunity that I saw. Like, we need to take this on and really figure out and get a focus for undergraduate medical education in particular as we build out and connect the dots to GME and graduate medical education.
Mm-hmm. So just for people who, kind of want to understand this legislative process, you say you saw an opportunity, a place where we could focus. What'd you do then? Did you have to get people together? Were you the one that initiated this work group? What does that look like?
Yeah, it was the process has developed as policymaking works. I saw how frustrating it was on the legislative side to feel like we haven't been able to do anything different than just invest more dollars in WWAMI. And again, I don't mean to talk. I'm not trying to make that sound negative, but that's the only option. That's the only thing that was on the table. Mm-hmm. And so that sort of collided in my thinking with this other sentiment of those that actually have not liked some of the things that WWAMI were doing. We had an abortion policy that they did not comply with. Mm-hmm. And so it kind of collided. And so what I saw is frankly an opportunity to say, let's do this different. And so the first iteration of this was let's change course from WWAMI. And so that's where we started. What we started was let's change course, and where we ended last session was being able to say we are going to build outside of WWAMI. Mm-hmm. We're gonna build something else out. We may have to reduce some of those WWAMI investments, but we're not going to do that for sure. But that's the compromise we ended up with last session with House Bill 368. Mm-hmm. But overall, the intent is to build out more UME and more options, and not to cut out something that's working. We want more options on the table. We want to know that we're getting the best return on investment.
Right. Because I think I saw somewhere that around, was it like 65-ish% or something? Depending on where someone does medical school, like where they do medical school, there's a high retention rate for that individual for where they do medical school. And for residency, it's actually an even higher retention rate. Kind of like what you're alluding to, that pipeline build. So yep. When you're talking about WWAMI and you're talking about all these, ideas, so the work group comes together, and who's on the work group and what kinds of conversations are you having in that work group?
Yeah, and so that was part of that legislation that we got to last session as part of saying, hey, we're going to invest in the next couple of years. We're going to invest 10 additional seats outside of WWAMI. We're going to start building something else. As part of that, we want to put together a group and build out a plan, a medical education plan. So part of that short-term investment is building out non-WWAMI seats for UME, and then build out a longer-term plan in medical education. And so let's have a working group to do that. And so we had legislative input, so that we limited it to a fairly small. It's actually, this is a kind of a little bit of a divergent, but a good point. Mm-hmm. When you put together committees or work groups, it's actually harder to do than you would think. Mm-hmm. You try to balance out, House and Senate. Sometimes you You have good reason to have majority and minority representation on those committees. There's also, do you want to have the executive representation on these committees? So it gets complicated as you try to build out who should be on a work group. But we limited it to 9, and we had a House member and a Senate member. So we had Senator Dave Lent and I, and we were the ones that ended up chairing that work group. And that's another kind of side note point. Don't put a work group in statute unless you want to be the one showing up every day to help make it
yes,
work.
exactly. Yeah.
But in any event, it turned out that we had industry representation on there. So we had the Hospitals Association, we had IMA, the Medical Association, represented on there. We had all the undergraduate medical education institutions represented. We had an ISU representative, a University of Idaho representative. They do the current partnership with the University of Washington right now with WWAMI. And then we had an ICOM representative, and we had a state board representative as well, State Board of Education. So we had a really good confined, but a good group that kind of with broad spectrum, but not too large that we could really work really well together. It turned out to be a really solid group.
Mm-hmm. And so you have this 36-month rollout plan, right? Like the group comes together, you have this 36-month rollout plan. People can go, literally can just search like undergrad medical education work group, Idaho. It'll, that will generate, and it's, I think I found it on the Board of Education's website. Yep. And, people can generate that and see that. And I do plan to have a solo episode just kind of dissecting some of those different things. So, we won't get into, the minute details here today. But one of the things that I'm often left thinking about when these work groups get together, which I think is great. And as you talked about, you brought a great, group of individuals together that are representing different areas. So you've got those different perspectives sitting around the table. Awesome. I love to hear it. And then you generate this great plan, like, here's this plan. Yeah. And then I am left thinking, okay, here's this really great plan. How are we going to make sure that actually gets rolled out? So what is the plan, or what is the vision for, the potential rollout of this? Because, to your point, a lot of really great individuals got together and did some really great work. And one of the things actually I think would be great to highlight here is that you guys did some like additional studying or diving into some different areas that other states haven't done yet and haven't looked at. So I'd love for you to highlight that too.
Yeah, those are great things to ask, because I spent a lot of time, I invested all of us did on that group. I invested a lot of time. We were aggressive. Like we knew, and when we got started, we were going to meet often, and we're going to do a lot of work. And the state board staffed this, and they did a lot of work, a lot of research for us, and prepared a comprehensive overview, not only of what is going on, what is the current state of medical education in Idaho, but what's happening across the country, and a deep dive. And I haven't seen any other state do what we did. And I think it truly is remarkable what we did and how we did it. And we worked aggressively to really compile the current state, and what are the opportunities, and what are the options, short-term, long-term, what are the things we are doing, could do, should do, might do, right? All those things. And it's all in there. It is a gold mine of all the options. But that's only as good, like you said, it's only as good as you put it into practice, right? You can implement some of those things. So again, that was one of my real concerns with this group is, let's have a product that the legislature will take serious, that the governor will take serious, and that we actually can start implementing some of these things immediately. I don't want a plan that sits on the shelf. I wanted a plan that, frankly, was evergreen. It can be updated every few years. It can be what you turn back to and say, here's our medical education plan. Let's go back and update and keep this updated, but now we're not starting from scratch. Mm-hmm. The next time we do this in a few years, we can just keep updating where we're going with this, but we have the template, we have the core plan sitting there that we've never had before. Mm-hmm. And I think we achieved that. We had a unanimous recommendation come out for that plan with our work group. Mm-hmm. And one of the things that we did is, compartmentalize those, like you said, the first 18 months, the second, options here. and prioritize those. We did an executive summary in front of that tries to, again, highlight some of the priorities and things we think they can do. And then I think each of us have our own priorities within that on the things we think we can push forward and accomplish. And, I have a couple of those that I could talk about that I think, try to do immediately that will make a difference.
Yeah, let's hear about some of those. What are some things that, we can expect to see unfold or hope to see?
Yeah, well, I think priority number one is can we figure out a way, especially in this budget year that we're in, to fund that additional expansion of those undergraduate seats that we said we're going to do.
And you're talking about those 10.
Correct. Because it's the law. I mean, it is in the law. We passed that policy bill last session. We just need to appropriate funds for it in a year that's very difficult to appropriate funds. And so that is one, so that we continue momentum on doing what we said we were going to do and not go backwards. Because I think as we build that out, I think we can have additional opportunities for Idaho and how we deliver medical education. Secondly is a coordination piece. Like I am laser focused on figuring out how we can get somebody full-time coordinating medical education in Idaho. We learned from what work the state board did and their team this year. They dedicated so much effort and resources to this. We really need somebody doing this and in charge of this. No legislator can do it full time. We really need someone that can take this plan and start managing and pushing the ball forward. And so that's one key thing to get going. Like we need a coordinator and we need someone that is either a medical education director or a medical education and what I call healthcare workforce director coordinator. And that's one very near-term priority that we've got to get put in place to be able to build out any of this.
Well, I agree with you because in all of my study, just in terms of like my PhD and studying, public administration and implementation, if you want to get something actually done based on the plans that are there has to be someone specific who's able to watch or help that unfold, and implement and be implemented. And it's, just like with anything else, there's like so many great ideas that are out there and people throw them out. But unless there is some type of a push and support to help it get rolled out, it just doesn't. And so I'm curious, when you're talking about these 10 seats, what does that what are the suggestions in the plan for those 10 seats?
Yeah. So there's really only two realistic options that we narrowed it down to because we don't have our own school right now. And so the realistic options, if we're not going to add WWAMI seats, are ICOM, which is a private school. And we purchase seats there, which we've never done, right? And we the other alternative is the University of Utah, which we've had 10 seats that we pay for, and we've had those for 50 years. Down in Salt Lake at the University of Utah, we've had those down there that we pay for every year. And so an expansion of that, or expansion of the ICOM seats, or both. And I think the conclusion I came to, and that I presented to JFAC earlier this year, is I really think we should highly consider doing both 5 and 5 and keeping our options open and trying to see how that works.
And when you're talking about purchasing seats, what do you actually mean by that? What does that actually look like? So people understand the purchasing of seats.
Yeah. So it's a state tuition subsidy is really what it is. The state is paying for the cost of, you can look at it like the state's paying for in-state tuition at the University of Utah, right? We're paying to bring down the cost of what the Idaho student that gets in there is paying. So we're trying to give them a better deal as they go to the University of Utah. Same thing with WWAMI, right? Like we're giving them a better deal if they accept that seat and they go to medical school with the University of Washington in the WWAMI program. They're going to get a lower cost than if they just go out of state to medical school.
Right. And so, and I mean, for people listening, I mean, medical school is expensive. I know we paid for it, as for my husband and I, we did that. But something that I think is interesting about the WWAMI program, so people kind of understand the and just kind of some of the components of it, meaning that, and DO schools are a little bit like this. MD schools around the nation are, often in areas where they have enough opportunities around them for medical students to mostly stay right near that medical school. So medical students don't have to be traveling, and medical school students don't have to go like kind of cold, go find different places to do years 3 and 4, which is all kind of practicum work. And at in those first 2 years, the medical student, so my husband and I, we went to Penn State. And so we were in Hershey. And so medical school there was 4 years. And the first 2 years were seat years. And they were right there in Hershey, Pennsylvania. And years 3 and 4 were also right there in Pennsylvania. I mean, there were some 30-minute drives, to other communities around there. And students could go somewhere else if they wanted to, if they were like, hey, I really hope to do residency, over in, I don't know, Oregon or something, that you can go do, you can go try to have an opportunity during year 3 and 4 to do that. But for WWAMI, those students are not going over to Seattle. The first year is up in Moscow, Idaho, right? And they're there. And so it's a little bit different. It's not this traditional kind of, you go and you're just there the entire time too.
Yeah, that's right. So that classroom time is up in Moscow. Like that's where they're doing that. And the University of Idaho is employing the staff, and they're the ones teaching, right? And they're doing that. And then you're right. Once they're out of the classroom phase of that, in years 3 and 4 in particular, they're rotating around anywhere in that WWAMI state region, right? To try to go and do their clinicals and get that more practical experience in those years. And so it's not where you can stay in Moscow and get that. They have to go out somewhere else to be able to fulfill years 3 and 4. And so that is what they're doing. But again, even on that piece, Idaho has not been in the driver's seat, in my opinion, on controlling. And again, I use that word control, but we are investing a lot of money.
Sure.
So to be able to have a say and kind of that rotation network and how that's really working, that's all coordinated by the University of Washington and the WWAMI program. And so, it's just one of those places that I think prioritizing Idaho and Idaho opportunities, there might be standards, and I know there are standards that the University of Washington is keeping, and when they have somebody they add into their rotation or not. And is that best for Idaho? I don't know. We know it's best for them and what they think the output is, but that's one thing that, I think we should have more attention on.
Right. And part of the reason I bring up that, the WWAMI program looks like this and they're going up to Moscow. I mean, when my family, when we lived in Lewiston, my husband actually taught some lectures up in Moscow. So he was working, in Lewiston as an oncologist, and he'd go teach some of the lectures. And it was fun because he actually knew some of the kids that were coming through because of, where he lived. And so for him, it was fun. Like, oh my gosh, this guy, this young kid, his older brother was a friend of mine or something, right? So he kind of knows these people. But it was interesting because we had friends when we were at Penn State who were also from Idaho. They were actually, I'm going to get this wrong, but I feel like in my husband's medical class, there were like 4 Idaho guys in his class,
That's awesome.
Which is pretty cool. And so, we're over there and learning about everyone's experience. And one of my friends who was over there, who had, her husband had done undergrad in Idaho, he had actually, I think he had gotten into the WWAMI program, so he could have gotten this in-state, tuition opportunity and stuff like that. But they had a few young kids. And so he actually chose not to go into the WWAMI program, and he came out to Pennsylvania instead, because he would have had to move around with his family, and he wanted his family to have more of a stationary spot, right? So where they were there in Hershey. And what was great was to sound like Penn State did some nice things for them. So tuition wise. But so I bring that up because it's not the program's great. My husband and I, we support the program, but it's not like you're just opening this door for people and it's not like it's this easy experience, right? These students who go in, let's just say that, medical school's hard anyways,
yeah.
But there is some they've got to move around, and that's not a dig on the program. That's a method to say, that's a means to say there is some challenges that people they're going to have to live through while they're going into the WWAMI program too.
Yeah, I think there are real challenges with any program, and that one of the things that amazes me when you're applying to school, and especially into the residency side of things, is I think the typical what I've heard of the typical student is applying to like 15, 18 different places to get in for residency, and usually they all get matched and go into their top 3.
Generally, yeah.
But there's a lot of factors that go into that, and I think we often forget when we're setting policy or like trying to figure out what we're investing in, the real effect of the family, and like what's the opportunity for the spouse and for the children or things, right? A lot of our medical school students are in that situation. They're not all single. Some of them or they're developing families at the time, and that all matters. And so I think your situation, right, like that, or that situation you brought up is very real. Like in Idaho, we probably need to do a better job again at coordinating alternative opportunities for families that would stay here and do medical school here if they didn't have to travel so far.
Right.
And I think that can be one thing that we can leverage and do a better job of, and should have more focus. We've just never talked about it. I don't think we've ever had any focus on that. I mean, somebody may have looked at it, but I haven't seen it.
Right.
Yeah.
Well, invite me to the table. I'm always happy to bring different perspectives for you.
I love it.
So, transitioning then into, I want to make sure we have some time today to talk about this $1 billion, because I feel like there's an intersection between this, this work group recommendation and this money that's come in, from the federal government. So talk a little bit about what this money is. I love to say $1 billion, but apparently it's just shy of $1 billion or something. But let's talk about that. Let's transition over to that.
Yeah. So the way this we're talking about the Rural Healthcare Transformation Fund, or the program that was rolled out by Congress this year. And the way that worked is all the states got half of the amount appropriated federally, and then all of the rest of the other half you got to bid for, basically put in an application and show why you have more rural issues that you need to correct and the delivery and outcomes with healthcare. And so we got our first award amount for the first year of the 5-year rollout of that $5 billion, and it's shy of $200 million. So right now we're tracking to be, less than $1 billion, but we hope to track pretty close to that over the 5 years. And that provides significant opportunity. That is a lot of money, right? At 200 million or 192, or, that's a lot of money coming into the state annually to go into improving rural workforce and the delivery and outcomes in in medicine and people's healthcare and changing lives. And so that's the objective, particularly that was the purpose for rolling this out across America, and is to address particular gaps in places where you can improve technology. You can improve just infrastructure, like things that just are there's not good ways to have a good facility when you're providing services out in some of our rural areas of our state. And one of the specific things in there is workforce, right? Like education and workforce development, which is one of the things I'm keyed in on as an opportunity here, developing out our rural workforce in Idaho. And so that's where I see that as an opportunity. As we've talked about some of these funding limitations in our current, fiscal situation, I really see this in a place that I'm honed in on, as we look towards, setting policy and what we're going to do, rolling out this funding coming into Idaho, is making sure that we're doing it in a good way to develop our healthcare workforce, obviously for doctors, but for our entire healthcare workforce, all the way up the ladder. Making sure that we're making long-term investments to improve how we are delivering education and connecting that to actual people getting into jobs and staying in the healthcare professions in Idaho. And so huge opportunity with this money coming in from the federal government.
So so a task force gets put together, and I went to your very first meeting. Have you had more than one now?
We had so you're talking about the rural healthcare
Yes,
legislative task
the
force.
legislative task
Yeah.
force. So, because you've got this money coming in and you've got this task force, and it's a legislative one we actually met right before that. And so then I went and sat in on it. So fun. This is like something I love about Idaho. I'm walking into the meeting, and this like lady, she like intentionally bumps into me, and I look at her and I'm like, yo, and it's my husband's sister's best friend growing up. And she happens to be the mayor of Fruitland. And
I love
so,
that story.
yeah. And so we go in and we sit down next to each other, and she's talking really quickly. She's like, "Hey, are you aware, of the, yada yada?" And I was like, "Oh yeah." And I was like, did you see the work group, recommendations?" And she says, "No." And I'm like this nerd. I'm like, "I have them right here. You want to look at them? I've them all printed out for you." And I was like, "Go to this page right here," and you gotta like see, she's looking at it. And while we're sitting there, here she is, the mayor of Fruitland. My husband actually works 2 days up in Fruitland at a St. Luke's clinic up there. He loves it. The people up there are just like so great. These, clinics in these rural areas they're just like such incredible people, and the teams are so important, and everyone who's in that clinic is important and matters, and they really love their patients that come in. But as we're sitting there listening to this, it's one of the first questions straight out of the gate is, how are we going to define rural, and what does rural mean? So tell me how, why that matters. I want to talk about why defining rural matters, but I also want to talk about who's actually going to be tracking this money and what the purpose is of the task force. Those two things are really important to me. So you go in whatever order you want, Representative, but those are two things I want to hit.
Well, you are asking a big question that none of us actually know exactly, but we all have opinions about. And so this is going to continue to settle out this legislative session and beyond. But the rural piece in particular, I think the rub there, or I guess the inquiry of like, this is something we need to keep a focus on is trying to make sure that it's a competing of interests, frankly, right? At the end of the day, that's what it is. Like, we want to make sure that if this is supposed to go to rural Idaho or rural outcomes, and improving that across places that traditionally just don't have other access to funds that would come in and make a difference. What does that federal definition of rural, or what they've told us it is, match with what we think it is in Idaho, right? And so is the Treasure Valley rural in Idaho? In Idaho, it's probably not, but so that's fundamentally the rub of trying to, that'll help us prioritize and have focus on how these funds and where they go out the door and who's able to be recipients of it. I would just say, though, all of Idaho and all of Idaho healthcare is connected. So as we do that, I think we're gonna have to be very mindful of understanding the impacts. They're all connected, and so to get us too disconnected because we're fighting over a word rural, I think is kind of misses the point. Mm-hmm. I think Idaho is rural, period, and everything we're doing to improve outcomes will benefit all of us throughout the state. But
I don't mean to interrupt, but I am in that I was having a conversation with someone and hearing about how hospitals, some of these larger hospitals are saying, well, we are technically, these large hospitals are connected to these rural hospitals too, because we're supporting, a lot of the work that they're doing there, or some of these hospitals do have these small clinics out in rural areas. So, there's that piece of it. But then like when we're talking about, defining rural and why this matters, and to your point, there's so many facets and perspectives that come into this definition. Ultimately, I heard one lawmaker on the task force say, we want to make sure this money goes to the places that need it, and that we're actually using it appropriately, and effectively, right? And getting it to where it needs, and not just where it needs the help, and not just letting it kind of all fizzle and be in the Treasure Valley, right? And finding this right spot where this tension lives of acknowledging that our big facilities are supporting our rural areas, but our rural areas, like these actual spots out in these very more isolated spaces in Idaho, are getting the support and the help that they need, in the way that they need it.
I agree with that. I mean, there's very strong opinions, right, about this and how connected those things are. If from my perspective, since we're talking a lot about just the education piece of this, whether if there's an ability to use some of that funding to support education, and that's taking place in the Treasure Valley, I don't want that to be lost, on the opportunity.
Right.
Because there might be an opportunity to build out some of that education workforce development here that impacts throughout the state. And so that's my point. But there's going to be a lot of strong opinions about that, because there's with this much money, there just is going to be a lot of interest. There's going to be a lot of interest at the table, pushing for where this goes. There's a lot of ideas already out there. And so we're going to continue to have that debate and figure out, where this is going to land as far as, where the investments are going to roll out. But I think you're going to see a lot of things. There's a lot of money. And so I hope we don't let that, limit us too much on the opportunities, on what's on the table, because I think that's going to be a problem if we spend all the time debating on rural versus truly looking at the output and the return on investment for Idaho. Then we're going to lose time and opportunity, and it's going to be frustrating.
Right. And I do know that in terms of like residency seats, I mean, this was something that I looked up too, that, and I mentioned earlier that, there's a very large percentage, let's say it's like 65, 70% of, individuals, like where they go to medical school, they stay for residency and they'll practice. But that number is actually even higher for residency. Like where people do residency, they have a much, greater pull then to stay in that state. And Idaho doesn't have very many residency seats, and we're short. I think I noted, I saw that we are, 50th per capita in the nation for physicians. And I think that we're 44th in the nation for primary care physicians per capita or something.
Right.
It's low, right? We're at the bottom of both. We are the bottom of one list and, nearly at the bottom of the other one. And so when I mean, these aren't your words, they're mine. And this is not the task force thoughts, they're mine. But when I see that $1 billion come in, and it's for, rural healthcare in Idaho, and then I see these recommendations from the undergrad medical, there is an intersection here. There is an opportunity to support both things in a way that creates quality pipelines, where students can see a clear opportunity for them and an investment in them, and then an opportunity for people to, an individual to actually be monitoring this and bringing all those pieces together so that it can play out in a way that benefits Idaho in all of the best ways, and especially those, rural areas. But that tension of making sure that we're using the money appropriately and stuff. But I feel like there's this great intersection of this undergrad medical education work group unfolding. And like you talked about at the beginning, where there was so much intentional work done and played in. And all of this, all of these dollars that come in. And, we're almost out of time. You have to get to the floor. But what can people expect in terms of accountability for these funds, and how can they follow along in the task force? So accountability of funds and task force, just explain that a little bit so people can know and be aware.
I think just stay tuned. I mean, I think what you're going to see legislatively is some sort of policy that gets set. The task force is one thing, but I think there's got to be some form of policy set on whether that's an oversight committee or how that's going to generally look that will participate in the oversight of these funds. We know how the Department of Health and Welfare has submitted a plan on how some of these funding would go, and I think you're going to see the legislature put together a plan to have oversight over the spending, and then helping prioritize and making ultimate recommendations for appropriating those funds through the legislature going forward. And so stay tuned to exactly how that looks and who's on that that committee and pay attention to that as that gets put together.
Are you talking about the task force, or there's another committee that's going to get put together?
Well, I expect there will be another committee. We'll see how that really comes together. Those are negotiations happening right now.
On the task force, or just legislatively?
Legislatively.
Sorry, I'm getting
no,
more
it
specific.
is very confusing, right? Very confusing, because I think we're figuring it out as we go, right? And how this is going to really work. So we have a task force, but I think ultimately the idea would be that we can get a task force. I would hope a task force that could be on board with some sort of recommendations to have an oversight committee that really helps oversee these funds going forward. The task force is just during legislative session, just to kind of make sure we're taking a look at how we put that into place, right? Put that into place. And so there's been a Senate bill introduced already on this. We'll see where that ends up.
Who's sponsoring that one?
Senator Cook has that one.
Okay.
And then, so we will see, but I can't predict exactly, because those are negotiations we're just not there yet.
Yeah.
But I expect as we get out of session, we'll have something as a little bit more of a plan. The last thing that I want is to have not have a clear process for how we're managing these funds. It's a lot of money to get out the door and to have our priorities straight. But we do have a process. We need to have a process that we have the public input and legislative oversight to be able to spend that money. And I think if we don't do that, we're gonna have more fighting and less building and doing. And so we need to have that process in place. We need to figure out how we're going to do it, and then we need to get everybody on board and then get the input and start moving. And I'm going to do my best to be a part of that.
So do you know how often has the task force set like specific dates yet?
We were going to meet every Wednesday, but I think the next time, I don't know the next date we were going to meet. Some of it's just been scheduling. One of the things we've been trying to do is get someone out from CMS, I believe, to come in and talk directly about this program.
CMS is?
Center for, now that you do that to me, I guess it's not CMS because that's Medicaid. So, so actually it'd be the Department of Health and Human Services, federal. So I'm glad you asked that, for clarifying, and get them out here and actually ask questions directly about this program. And so we're getting it, directly from what they know, but they're figuring it out too as they go. This is brand new for them. They're rolling it out nationwide. I think there's going to be some adapting as we all figure this out together. It feels a little bit like we went through with ARPA, a ton of money, fiscal recovery money coming in through those COVID years. So that gives us some history of a lot of money coming in and what we're going to do to get it out the door. We've done this with broadband money in the past. We're managing a lot of that. And so we have models that I think we can rely on for legislative oversight and being able to do this. We just need to figure out some of the details, who are on those committees, and get to work.
So if people are curious and they want to follow along, where's the best place to go for information for this? Because it can't be me, because I don't know yet.
There's not a good single source yet. As soon as we get a statute or something passed that really shows how this is going to be, the legislative involvement in this, then I think you'll start to see this consolidate and a place of who's managing this, who's staffing it, and then how it's going to come together. So there's not a great place yet, but there will be.
So what I'm hearing you say is that I am going to have to keep emailing you to ask you my questions to know exactly where I'm supposed to look so I can share it with everyone else. Yeah. Is that what I'm hearing from you?
Yeah.
You keep getting emails from me.
You might get a different answer daily until we get this put together. So just take that with a grain of salt. Yeah.
Well, Representative Manwaring, I've said that right this time.
You did. Good job.
Thank you. I really appreciate you coming in. It's been a great conversation. I care deeply about this. This is a topic I care deeply about. So I definitely am going to be following along. I hope you come back on again so we can talk more. And I really appreciate the work you're doing at the Capitol. Thanks so much.
Yeah, that's awesome. This is one of those conversations that I think almost creates more questions than it always answers. It's a topic that just has so many layers to that onion. And so, as we get more information, especially on this rural healthcare funding, we're going to continue to have these conversations, right? And we need the input. We need more people paying attention and sharing what the priorities should be. And it's been fun to have this conversation.
Awesome. Well, so stay tuned for everyone. More information will come out. Thank you.
Yeah. Thank you so much.
And that's a wrap for today's episode of The Purple Zone. Thanks for being here. If you liked what you heard, leave a review on your fave podcast app or on YouTube. And from me to you, the heart of The Purple Zone says community is where policy comes to life.